Dear students, welcome to my new class. This is my 8 lectures about the thyroid and anti-thyroid drugs. So in this lecture we will cover all these objectives, review the physiological effects of the thyroid hormone, identify the effect of hypo and hyper secretion of thyroid hormone, discuss the action, indication, side effect and contraindication of thyroid and anti-thyroid drugs, integrate the influence of thyroid and anti-thyroid drugs on the metabolism of other drugs, teach clients self-care activities related to the use of thyroid and anti-thyroid drugs, and calculate the drug usage accurately. Before starting pharmacology, so you must will have to know about the little bit physiology of thyroid gland, that what is thyroid gland and what are the different hormone which is secreted by the thyroid gland. After that we will talk about the drugs. So in thyroid physiology, first of all I would like to say that we know that thyroid gland, this is the gland which is situated at the base of the neck, and they are responsible to secrete different type of hormone that is called thyroxines. Thyroxine is further divided into two, one is T4 and T3. So T4 is called tetraiodothyronines and the second one is triiodothyronine. Its secretion ratio is almost T4 to T3 is 15:1. The iodine is directly attached to the tyrosine amino acid. The residuals of the thyroglobulins and the adrenal glands organification can be done. So organifications, actually it is a biochemical process that take place in the thyroid gland. As we know that it is the incorporation of the iodine into the thyroglobulin and the production of thyroid hormone. So a step is done after the oxidation of the iodide by the enzyme thyroid peroxidase TPO. So the coupling of these residues then produce T4 and T3. Tetraiodothyronine and triiodothyronine, they are released by the gland, which are bound and transported by the serum protein. So the first one is thyroxine binding globulin, that is called TBG, which is 75%. The second one is thyroxines binding pre-albumin, that is called TBPA. So the pre or unbound hormone levels are the levels which are maintained constant by feedback and regulate thyroid function, while the total measured serum T4 include bound and unbound form. Now what is thyroxine binding protein? What is the reason through which we can find out why the level of TBG level it become rise? So the thyroxine binding protein and the thyroxine binding globulin level, why the thyroid binding globulin level it become elevate. So the level of thyroid binding globulin is elevated it may be due to pregnancy, or it may be due to estrogens, which are the female sex hormone which control the secondary sexual character of the female, while in case of cirrhosis, liver cirrhosis, hepatitis and porphyrias. So actually these are the conditions due to which the level of TBG, thyroxine binding protein, or you can say the thyroxines binding globulin level, it become high. So these are actually the condition through which we can say that why the level of TBG become elevated. So there are 4 reasons: whenever there is pregnancy, or whenever the estrogen level, so it may be due to estrogen, or it may be due to cirrhosis, or it may be due to hepatitis or porphyria. So porphyria, actually it is a condition, porphyria. So porphyria is actually the rare hereditary disease in which there is abnormal metabolism of blood pigments like hemoglobin occurs. And porphyrins, these are the compounds which are excreted in the urine, and the urine become dark in colors. What are the causes of decreased TBG? Now why the TBG, the thyroid TBG level, the thyroxine binding globulin, the thyroid binding globulin level become low or decrease? So the reason is that there may be chances of protein malformations or nephrotic syndrome, hepatic failures, androgenic steroid and high dose glucocorticoids. As we know that free T4 tetraiodothyronine tetraiodothyronine, and FT4, you can say, usually constant in the above conditions. T4, it is also called tetraiodothyronine. It become deiodinated in the periphery to T3. This is 80% of the T3 produce. Other metabolite of T4 is reverse T3 or RT3, which is metabolically inactive. The T3, the tetraiodothyronine, it become enter in the cells and bind to the group of nuclear receptors. So its binding is directly to the nuclear receptor, and then it can affect the wide range of cellular metabolic function. Thyroid hormone required for the normal cell metabolism. So for normal cell metabolism, the thyroid hormone secretion is important. For example, if thyroxine, they are produced in lesser quantity, so this is also, it also doesn't meet the requirement of your body. If its secretion become abnormal, so this is also, you can say, for body adjustment, equilibrium is required. Now these are the steps of biosynthesis, how these triiodothyronine, how thyroxine, they are produced, how they are formed inside the body. So biosynthesis means how they are produced inside the body. So the first step is the phenomena which is called iodide trapping. So the iodines or iodide, it become trapped inside the cells. And step 2, the oxidation of iodide to iodine occur. And step 2, the oxidation, the iodide, it become oxidized and it converted into iodine. While in step 3, the iodides, the organifications of the iodides, it become done. So as we have already discussed that in step 3, the iodide organifications, they are take place. So organification, it is actually the biochemical process that is take place inside the thyroid gland, as I have already discussed, that actually the incorporation of iodine and the thyroglobulin for the production of thyroid hormone, as this is done after the oxidation of iodide by the enzyme thyroid peroxidase. While in step 4, the formation of T4, tetraiodothyronine, and T3 is occurred. So this is step number 4. After, when the iodide organification can be done, this biochemical process can be done. So in post step, the formation of tetraiodothyronine and triiodothyronine can take place. So they are formed. While in last step, step 5, the T4, tetraiodothyronines and thyroxine, they are released. The compensatory mechanism of actions of thyroxine, how these hormone, the mechanism of action of thyroid hormone, that how these hormones are secreted from the thyroid gland. As we know that gland is a cell or the group of cell which is responsible for some particular secretion which are called hormone. Preform of T3 triiodothyronine and T4 enter the cell by diffusion or active transport. T4 is converted to tetraiodothyronine, is converted into triiodothyronine, and then it become enter in the nucleus and bind to T3 receptor, because there are particular receptors, as we know that there are particular receptor for their drug. So in the same case as hormone, so there are some particular receptor for that hormone which can bind with it and then it show their activity, because as we know that hormone, these are the chemical substances which is produced by the endocrine glands and secreted by the Duplex gland, and then they can pour their secretion directly into the blood. So T4, when T4 is converted into T3, tetraiodothyronine is converted into triiodothyronine, so then it enter in the nucleus and bind to the T3 receptor. This will lead to increase the formation of messenger RNA. So when it increase the formation of messenger RNA, and the subsequent protein synthesis can take place, and this process is known as transcriptions. Look at here, this is also the mechanism of action of thyroid hormone which I have mentioned there, that the free form of T3 triiodothyronines and tetraiodothyronine enter into the cells by diffusion or active transports. So the T4, they are converted into T3. The T4, they are converted into T3. So when the T4 is converted into T3 and then it enter into the nucleus. So when it can enter into the nucleus and bind, when it enter into the nucleus, then it bind with the T3 receptor. So when it bind with the T3 receptor, so this will lead to what? This will lead to increase the formation of messenger RNA, and subsequent messenger RNA is formed and the protein formation is take place. So this is the simple mechanism of action which is starting from here. So the pre-protein of T3 and T4, they can get enter into the cell by diffusion or active transport. The T4 is converted into T3 and then enter into the nucleus, and after entry into the nucleus it bind with the T3 receptor, triiodotyrosine receptor, and this will lead to what? Increase the formation of messenger RNA, and subsequent protein synthesis can take place. Now come toward the pharmacokinetics of the administered thyroid hormones. Now come toward the pharmacokinetic. As we know that in pharmacokinetic we are studying about how the drug will metabolize, how the drug will absorb, how it can be transferred, and how it can be eliminated from the body. So the pharmacokinetics of administered thyroid hormone, as we know that T4 is the best, you can say best absorbed in the duodenum and ileum, which is the first part of the small intestine, and ileum is the, so tetraiodothyronine is quickly they are absorbed in the duodenum and ileum, and this can be altered by food and drugs such as calcium preparation and antacid containing aluminum intestinal flora. The absorption of tetraiodothyronine is almost 80%, and the absorption of triiodothyronine is 95%. So the absorption is not affected by the mild hypothyroidism but impairs in myxedema with the ileus, and the condition is parental root and Fripper. So what is hypothyroidism and what is hyperthyroidism? So as we have already discussed and the diseases, so you must will have to clear your concept about the hypothyroidism. Please study more about hypothyroidism, what is myxedema. So after that you will know about the pharmacokinetic of administered thyroid hormone, and inshallah I will discuss in my upcoming lecture. So in this condition the parental root is prepared because the absorption is not affected by the mild hypothyroidisms. Now I am going to compare T4 to T3, tetraiodothyronine to triiodothyronine. So T4 production is more than T3, and T4 is converted to T3 in the periphery, while T3 is more potent than T4. T3 acts faster than T4, mean tetraiodothyronine act faster than T4, but T3 enters the cell easily than T4, but T3 bind to the receptor and the nucleus, as I have already discussed the basic mechanism that how this hormone can be secreted from the thyroid gland, and then it can bind with particular receptors. Now another question is that how to regulation of thyroid hormone, how thyroid hormone they are regulate, how it can maintain its activity throughout the body. So you can say regulations or maintenance of thyroid hormone, the normal regulation required intact hypothalamic pituitary systems. As we know that pituitary gland, which is called the master gland of the body, which is also known as hypophysis. So hypothalamus secrete thyrotropin releasing hormone. So this point is clear that hypothalamus, as we know that pituitary gland, which is called the master gland of the body, and it controls the overall activity of the body, how much hormone, so they are under the control of this pituitary gland, and which is present at the pituitary fossa. So after that the hypothalamus secrete thyrotropin releasing hormone. So thyrotropin releasing hormone, it then stimulate the synthesis the synthesis and the release of thyrotropin, thyroid stimulating hormone, that is called TSH, by the anterior pituitary gland. The TSH, thyroid stimulating hormone, then stimulate the thyroid gland to uptake iodine synthesis and release T4 and T3. T4, tetraiodothyronine and triiodothyronine, its level feedback to both hypothalamus and pituitary, affecting TRH, thyrotropin releasing hormone, and what? TSH, thyroid stimulating hormone. Now this is the same mechanism how the hypothalamic, pituitary and thyroid axis thyroid regulation can take place, as I have discussed already, that we have already for normal, these are different type of hormone which is secreted here. So this is T3 and T4. This is cold area. This is acute psychosis, circadian and pulsatile rhythm. This is severe stress conditions. So you can say these are positive and these are positive and these are negative, and this is hypothalamus, corticoids or dopamine and somatostatin. So different hormone, how these hormone can be secreted from the, so as we know that human body temperature, that is 37 degrees centigrade, that is also maintained due to hypothalamus. So as we know that there are different type of activities, so inshallah I will discuss in detail. Now look at here, hypothyroidism. So as we know that hypothyroidism means when the thyroxine production is low. So what are the signs, symptoms of the hypothyroidism? So there may be chances of cold, intolerance, dyspnea, difficulty in breathing, anorexia, loss of appetite, constipations, mean the stool you become hard, menorrhagia or amenorrhea, abnormal menses, and arthralgia, myalgia, pain in the joints, pain in the muscles, fatigue, depression, irritability, sensitivity, decreased attention, and memory, paresthesias, memory lapses may be occurs. So these are the hypothyroidism. This is, you can say, high LDL. You can say these are the different effects which are given here. So whenever a person who have a hypothyroidism problem, so it is easily to diagnose. If you think of it, there will be a condition like that: slowing up mind and the body, weak heartbeat, constipation, myxedema, slow reflexes, high LDL, low density lipoprotein, hair thinning, depression, schizophrenic, irritability, back tongue, croaky voice, dry skin, and cold intolerance. The sick and hyperthyroidism, these are the signs. So if a person who is suffering from hypothyroidism, when adds thyroxine secretion as low, so these are the signs which are reported. Dryness, you can say dry, yellow, keratinomics, skin weight gain, 41% of the cases, thinning, coarse hair, myxedema signs, mucopolysaccharide deposition and the tissue. So look at here, these are the what? This is hypothyroidism, because the thyroxine, they are not properly secreted here. So you know, this is buffy eyelid, you can say buffy eyelid, and hoarse voice, dependent edema, and carpal tunnel syndromes. Primary hypothyroidism. So primary hypothyroidism, this is actually autoimmune. Most common, some have lymphocytic infiltration, variant post-surgical thyroidectomy. The external radiations, iodine 131 for hyperthyroidisms, severe prolonged iodine deficiency, anti-thyroid medications such as lithium salts, lithium inherited enzymatic defects, and true idiopathics, hypothyroidism, and myxedema, coma. So these are the cases which are reported. So it may be chances of hypotension, bradycardia, and pericardial effusion, low voltage EKG, prolonged QT interval, and inverted split T waves. So now we are going to perform different type of tests, like thyroid function test, that is called TFT. So free tetraiodothyronine index, that is correlate with the level of free T4 or T3. Radio immunoassay less useful. So normally 75 to 195 grams per deciliter serum TSH, thyroid stimulating hormone. Normal is 0.3 to 5.0, so this is the normal range. And ml, so TRH stimulations test measures TSH response to TRH IV injection. Normal it is increase and thyroid stimulating hormone to 30 MCU for mLs. So inshallah in next lectures I will discuss about the different type of hormone preparation, thyroid hormone preparations inshallah, and its basic pharmacology. Thank you so much for watching my lecture.